Hi, I'm Aimee Allbritton, one of the Senior Vice Presidents here at Memorial. I'm serving as our organization's Public Information Officer during the COVID-19 pandemic, and I have today with me Dr. Linda Jones. She is our Vice President of Ancillary Operations for the health system, but she's serving right now in a capacity as Testing Director around COVID-19. She's here today to share information with us about testing and all the questions that you've been asking about the testing process. Welcome, Dr. Jones.
Thanks for having me today, Amy.
We're glad you're here. So tell us a little bit about COVID-19. What do we need to know about this before we talk about testing?
Well, as you know, COVID-19 is a novel virus that was first identified in China in late December when they first announced to the World Health Organization that they had mysterious cases of pneumonia without a known cause. Today we know that this novel virus is a coronavirus that's closely linked to the SARS virus and the MERS virus that have also caused pandemics in the world. China's saying today that even though they first announced this virus in late December and then January 2020, that maybe this virus existed earlier in their population, and today they've traced it back at least as far as November 17th.
Is that why it's called COVID-19? Because they found it in 2019?
That's correct. Yes. It actually is the coronavirus 2019, or also known as the SARS-CoV-2, because it's so closely related to the SARS virus.
Yeah, and this is what it looks like, right? Not a friendly fella.
No, this is an actual picture of the virus under an electron microscope. So you can see the spikes on it that's commonly associated with this virus. And one of the ways that it's thought that it can easily cling to and invade cells.
It looks like it could be dangerous, right?
It looks like an evil virus, doesn't it?
It does, yes. So one of the things that we're getting a lot of questions about is who can get tested for COVID-19. Can you share what we know right now about testing?
Well, this has been a rapidly changing picture of who should be tested. And obviously, it's painted onto the picture of the difficulties we've had with mounting enough testing in the United States. But what I'm showing here are the latest IDPH, Illinois Department of Public Health guidelines of where their priorities are for testing in communities. So it begins with hospitalized inpatients with suspected disease. The reason that this takes the top of the list is that these individuals have a great ability to infect our healthcare workers at the front line. It determines whether or not we needed to be using all the protective equipment in our hospitals, and they're very resource intensive patients in terms of needing ICU beds, ventilators, and other types of healthcare resources. We've learned, though, that there are vulnerable populations out there that we need to quickly identify and be able to put resources around and quarantine these individuals. And so IDPH has also said that any resident in a congregate setting. Now we think of a congregate setting might be a nursing home or an assisted living facility, but there's lots of other types of congregate settings. High-rise buildings where people are sharing facilities such as storage facilities or laundry facilities. Prisons are an excellent example of congregate settings. So these populations need special attention to assure that their close contact with each other doesn't facilitate the spread of disease. Also, outpatients who are at the front line of caring for our communities. So these are individuals that are considered essential in the fight against COVID-19 and maintaining the safety of our communities. Examples would be police, healthcare workers, EMS providers, firefighters. These individuals who are showing symptoms should be tested. And then again, outpatients themselves who are employees taking care of residential congregate individuals. So the employees who work in residential homes, nursing homes, prisons, etc.
Officers, things like that.
Absolutely. And then the last category, the fifth category actually on here, are the individuals that we are testing outside of these guidelines. And this is what we're doing in our drive-through clinics. In addition to testing these individuals in the first four of the list and sending them to IDPH, these are the individuals whose tests are being sent to outside laboratories to test for symptoms when individuals have comorbid conditions.
Okay.
And by comorbid conditions, these are things that will put people at additional vulnerability to have this disease. So we're currently testing individuals who are immunosuppressed, individuals who have had transplants of their organs, individuals who have inflammatory diseases and take immunosuppressive drugs, cancer patients, and there's even some alteration in the immunology for pregnant women.
Okay.
So we're looking at all of those individuals. Today we have to put the clinical picture together with this to make a determination about whether testing is indicated.
So what does that mean for people that are often called the worried well, right?
Yeah.
So there's people who say, I just want to get a test. I want to know if I have it. I'm not feeling 100%. That could be related to a lot of things. But is there somewhere they can go and just get a test because they're worried, even though they might not fall into one of those categories?
Today there really isn't. We're really testing individuals with symptoms. And the reason that we're doing that is that we don't know the ideal development of this disease and when we really have virus present. So it's probably helpful to talk a little bit about laboratory testing to answer that question about should we be testing worried well or asymptomatic, those without symptoms. So here's just a little bit of background about what makes a good laboratory test. So is it readily available? Yes, we know in this situation we don't have all the test kits that we want, and I'll talk a little bit about that. Is it easy to get samples? In this situation, we have to use proper protective equipment, especially in individuals with symptoms, and we know that even individuals without symptoms could be carrying the virus and could be spreading the virus. Tests need to be safe to handle. So the routine blood tests that we do to check your blood glucose, that's easy to handle. In this case, our blood samples, urine, sputum, nasal swabs, these are all potentially contaminated. And we have to handle them carefully in the clinical areas and in our labs. Getting fast results is important, and I'll talk to you a little bit about how we're trying to move that.
Yeah,
we're trying to move hard. We're moving that needle, I think, but it's difficult. And then tests that are accurate and reliable. This is particularly important in today's world because we're allowing to have tests moved up in their research cycle to be approved by the Food and Drug Administration. So the FDA is approving a lot of tests under what they call emergency authorization. And so they are allowing companies to submit small sets of data rather than the large, well-studied sets of data in the past.
Interesting.
And then cost effective, and I would say that's the least of our worries right now. We need these tests to get into the marketplace and be available for clinicians to use. So here's some other issues related to testing that really puts this in perspective. You need 4 steps just to get the test to a lab and get it tested. This isn't everything that goes into a lab test, but important here. First of all, you have to have a test kit. In this case, most of these tests are being done using a nasopharyngeal swab and getting some mucus from the back of the throat. And this picture shows that, how to get a clinical sample. You insert this long swab through the nasal pharynges, the nose itself, and try to get to the back of the throat to actually collect the sample. And then you have to have a piece of laboratory equipment. And what we've been seeing in the U.S. area is large numbers of companies trying to develop a test for their own specific lab equipment.
Because we have the equipment, if we have the swabs and we have the people who need it, you have to have these last 2 components.
You have to have these last 2 components. And so that's where the issue is come up testing, is that we're seeing new tests come into the marketplace almost daily now. But again, every lab doesn't have this piece of equipment. This is one of the pieces of equipment that evolved into the marketplace relatively early with this test reagent kit that can be put on the machine with a sample to do the test. But a lab cannot do this unless they have this piece of equipment.
They need to have the equipment and the reagent to be able to do that.
Right.
It's kind of like at home, you can say, well, we want to have enchiladas for dinner, but if you don't have cheese and you don't have enchilada sauce and you don't have the meat, you're not having enchiladas, right?
Absolutely.
We need to have
all these
the
ingredients go together.
Yes, okay.
They all go together to really get efficient and complete testing.
Okay.
So here's another interesting perspective about the COVID testing and why we're really struggling as a nation or even as a world as this whole crisis evolves. It wasn't until late December that China announced through the World Health Organization that they were seeing a mysterious pneumonia and had seen at least one death at that point. And on January 7th, a Chinese scientist actually identified this as what was called then a novel coronavirus. First time seen coronavirus.
And novel because new.
Brand new.
Right? Yeah.
Brand new. I think there was immediate recognition that this new coronavirus would be related to others known. Now we have some very aggressive coronaviruses such as the MERS and SARS viruses I mentioned before, but coronavirus can cause the common cold as well. So differentiating it was very important, and in early January the Chinese also did the genetic sequencing of the virus. Once genetic sequencing was done, scientists knew immediately, I can use this new information to develop diagnostic tests.
Yeah, now they know what they're looking for, right?
And we have this technology that uses the genetic makeup of a virus to do the detection with this equipment that I showed you. So Germany had already started developing a test before the genetic makeup was known, and then was able to quickly adopt it to the new genetic makeup. And they were the first country in the world to actually have a detection test. They actually exported it to China to help them. Later on in February, the CDC developed their own test. And I think that's been widely criticized in the media about how that early testing failed. There was a piece of that test that did not work well. They began to dispense it across the U.S. to our state health departments, and immediately was known that there were problems with that test. A decision was made to continue to develop that test rather than to import tests that were already proven in other countries. So that did cause delays for us. Later in February, the FDA approved that hospitals and academic medical centers that had the scientific resource internally could develop their own tests. And a lot of centers moved forward and did that. And then we began to see commercial companies as well begin to develop tests into March and April. So you can see here with the timeline at the bottom here that we are 90 days out now from when we first saw and recognized this novel coronavirus.
So a lot's happened in 90 days, but sometimes to people it doesn't feel like it's enough, right? When we're hearing concerns that there aren't enough tests available, or people who believe they're symptomatic and they want to get tested. But this is part of this whole notion of this is so brand new, right? We're just working through it, trying to understand it, and new guidance is coming out every day, right, about how this works.
Well, and this is really innovation day by day, step by step. And I think that that's adding to people's frustration. This is a crisis. This is a world crisis. People are very sick. It's really changed our whole economy. Many people are dying. We have to respond quickly. But if you really look at the way we've innovated with this, we have had a quick response. It's truly not been good enough.
Right. And that's where the concern comes in, because you want it to move fast, but you also want it to be accurate, right? And when you talked in here about sometimes going fast can actually impede that accuracy. So it's finding the balance. It's also, we as a society are very used to quick results and quick turnaround, because if it's the flu, they can go in and get a quick flu test or a rapid strep test, and they're used to that. This is different, right? Because it's taking time to get these results back.
And we're learning more every day, but we think there's, it could be up to 2 weeks to actually develop the full-blown symptoms of this illness. And in the early period of this, even though you might be infected, you may not have enough virus in your body to be detected with the tests we're using today.
Which goes back to the worried well. We don't want people to get tested if they're not actually have enough of the virus for it to show up positive, because then they could have a negative but actually still be positive.
They could have a false sense. They could have a false sense that I don't have this illness even though I might have been exposed. And then it's really important that we give correct diagnostic information, because the most important piece of this is quarantine and social distancing.
Yeah, absolutely. So we're talking right now about the testing to see if people have the COVID-19 virus, but there's also been lots of talk about the antibody testing. We've seen that popping up more and more in the media. Can you explain to our viewers a little bit about those two types of tests and what they're for?
Right, and I think the most common diagnostic test used in the United States is the PCR test, or what's known as the reverse transcription polymerase chain reaction.
Say that twice fast.
It's a big mouthful, but this test has been around for several years, and it actually detects some of the RNA, or one of the basic building blocks of the virus. And positive results show that the virus is actually present. The biggest thing about it, as I mentioned before, it's highly dependent on the timing of the test, doing it during active infection, and having good sampling technique. So we're looking at several different types of body fluids that could be used for this test, but the most common one is using the nasopharyngeal swab and just getting some mucus from the back of the throat. The FDA recognizes this test as the gold standard for diagnosis of coronavirus, or the COVID-19 illness. How many other countries accomplished large numbers of testing was using this serology test for antibodies. This is a blood test, and it shows you whether you're developing the autoimmune antibodies that are present when you've been exposed to a virus.
So for our viewers, an antibody, give them the most basic definition of what an antibody is and what that does for you. Why is that important? What do they need to know about that?
Well, that's really your basic immune cell function that has to do with a challenge to any bacterial or viral illness. So we can tell whether you've been exposed to an illness by checking for your antibodies. These tests are supposed to be specific to COVID-19. However, one of the downfalls here is that under the emergency use guidelines, the FDA is allowing people to bring some of these tests to market without actually demonstrating that they work. So we have some tests that are actually going through the emergency use utilization process, but the FDA has basically said these are harmless tests. You can do them just with a pinprick. You know, it might have been helpful for me to show what a cartridge looks like for doing these tests, but it's very simple, much like doing a urine pregnancy test at home. You get a little cartridge, you put a pinprick, 1 drop of blood, it's all that's needed.
Send it in.
And it's in the cartridge, and the cartridge comes up with a line showing that there are antibodies present, or no line and no antibodies.
And that could, in theory, then help people understand their own future risk if they understand what their past exposure has been.
They could be. I think that one of the interests in this antibody test in the U.S. is not related to using it for diagnosis, as has been done in other countries, but really showing the worried well and their exposure. Did you get exposed? Do you have antibodies? Could you go back to work or back to other settings where multiple people are because you are immune to this disease? And then it might also be predictable for us about when we have a vaccine available, who needs to be vaccinated.
Who actually needs to be vaccinated against this, like we do every year with the flu and other things. So that gives us an understanding of what's going on kind of at a world and a national level. What about what Memorial Health System is doing for testing?
So this has been a changing table, just like everything else here. We have made multiple decisions along the way about how to test, and how to get this testing out into our community. So the testing started with our Illinois Department of Public Health, following guidelines set by our federal government through the Centers for Disease Control and Prevention in terms of who should be tested for COVID. And we've continued to work closely with our county health departments and with the state health department following their guidelines. Over time, as I've mentioned, commercial labs and academic labs have developed their own testing, and we've expanded our testing profile beyond the IDPH criteria into more of the community-based individuals who have comorbid conditions or might have additional vulnerabilities that IDPH does not test for. Those types of testing go out to our 3 outside labs for turnaround time. Now our IDPH has been able, as they've caught up with backlog and demand, to return our test to us in 24 hours or less.
Which is impressive, right? Because when it first started, we were seeing much longer turnaround time, sometimes up to a week. But then there were some guidelines put in place that allowed for them. They're running on multiple shifts instead of one shift. They're running through the weekends. So as you said, kind of the package of them that were sitting there, they've now moved their way through. So now when something comes in, it can get tested and get back out the door faster.
Absolutely. And with our commercial labs, they absolutely got overwhelmed by the first crunch. There was a large demand up front, but each of our...
It's like Black Friday. Right? Black Friday shopping, everyone shows up at the same time and they have to figure out how to get through it. Now it's kind of calmed down a little bit and they're managing it.
These first 2 labs that I'm showing you on this list, they've processed over 1 million samples already. So they've been working very hard to get their operations up and get them smoothed out and adding resources to
and
those.
This is something that 120 days ago they didn't even have on their radar they were going to be doing, and now it's the majority of their work, right? So it's all that scaling up that you're talking about. These companies have figured out how to adjust to be able to meet this need.
I mean, they've had to add additional equipment, additional individuals to be able to test 24 hours a day to get these samples out the door. And in the beginning we saw very lengthy and somewhat unacceptable delays, 12, 13 days even for some of the tests. But we're seeing that get into more of a control phase now, and we're seeing turnarounds in their original promise 3 to 5 days.
That's wonderful.
And you know, we recently added Mayo Clinic, which is one of the academic centers running their own testing, and they're turning things around in 48 to 72 hours.
And part of that is the travel time, right? This isn't something you can send across the internet. We have to get that sample from the patient in our community, and it physically has to be taken through courier to their facility and get tested so the results can then come back to us.
Absolutely. And every step of the way, the laboratory has to be responsible for that specimen. These specimens need to be refrigerated or even frozen for transport. So they have to come back to our central hospital labs, make sure they're labeled appropriately and that they're being handled appropriately on handoffs to our couriers. So then also, there's newer lab-owned equipment. So we're fortunate in that we have 2 different platforms owned by Memorial, one by Cepheid Company and the other by Abbott. But again, both of them new to the marketplace, struggling a little bit to get enough test kits out there, but we have learned that Cepheid is going to be able to provide us with test kits for 4 of our 5 hospitals, and we're hopeful that we'll have that yet this week.
Which is amazing, because then the turnaround time, particularly for our inpatients, will be, what are you expecting a Cepheid test to be?
Well, I'm going to skip that slide and I'll come back to it, but this one here is that we hope to introduce this testing. This actually shows the actual equipment, and you can see that the testing kit is a little cartridge, almost like an ink cartridge.
Like a printer cartridge, doesn't it?
And you just put it into these little drawers within the machine. We can turn around a result in 45 minutes.
Wow. That's amazing.
That is amazing.
So that allows us to provide the patient care faster, and it also has really significant implications for the personal protective equipment that we're using, because right now when we have a patient that we're waiting on timing, sometimes, as you said, 7, 10 days, even 3, 4 days now, the entire time that patient is what we call a patient under investigation, we're treating them as if they're COVID-19 positive in terms of the PPE that we use. The faster we know that they're a negative and they don't need that PPE, the more that allows us to conserve it for when we need it, correct?
Absolutely. This is one of the most important points of this, but there's
Yeah.
many others. These people need to be in special isolation
Absolutely,
rooms.
yeah.
They need special care provisions.
Mm-hmm.
They may need more critical care resources, more ventilator support.
Yes.
The course of their illness is particularly rapid and challenging.
Yes. Yeah.
So it's really important that our care teams know whether or not this patient is positive.
Absolutely.
And actually, one of the national issues for us is how many healthcare workers are being exposed as well.
Right,
So
absolutely.
having a rapid diagnosis can make an amazing difference to
really
the appropriate care for these individuals.
Yeah, that's fantastic. And you think we should expect to be able to have that on site by the end of the week?
I
maybe?
do hope so.
Yeah,
We've been told that testing supplies have been shipped to us, so we're anxiously
and this
awaiting
was
them.
equipment that Memorial Health System already owned, and our 4 hospitals, our newest affiliate, Decatur Memorial, didn't have the same equipment at the
actually,
time? Or?
our Decatur Memorial does own this
Okay,
equipment.
okay.
It's just our Taylorville Memorial Hospital. But again, we'll be doing this testing for all 5 hospitals and transporting specimens internally
So
to get
even though
rapid
Taylorville
turnaround.
doesn't have the equipment, they're still going to benefit because we're going to do
Absolutely.
that for the patients
Absolutely.
within the health system and within the community.
So we'll be prioritizing the inpatients as our highest priority for this testing to make sure that we can keep our patients safe and keep patients safe during transport, you know, internal to hospital, external, you know, we'll know right away if they were brought in by an ambulance crew, were they exposed, we'll have much more information at hand to be able to track through and do the appropriate care.
That's fantastic. It's really good news.
Yeah, it is good
That's
news.
good. Okay. What other thoughts do you have that you want to make sure that our viewers at home understand about testing?
I just will tell you this additional information about the antibody testing.
Sure.
Today there's just one approved test. As I've said before, the FDA does not require a full set of data to be submitted to give this emergency use authorization. And you know, we would love to have antibody testing under our gold standard of looking at before you got the illness, after you have experienced the illness, and also during the recovery phase. But at this point with the emergency use authorization, we allow much smaller size samples and much restricted requirements in terms of testing. So we have one test that's gone through there, but over 70 tests are currently in development. Our companies are trying to claim that they can do this antibody testing. So I think we'll see this out in the community and even be a home-based test as well. But people just need to be careful about it. has limited utility and the reliability of these tests is much lower.
Sure. And I think as we look at this, you know, my grandfather always used to say, oh, if you don't like the weather in Illinois, just wait a few hours and it will change. That's a little bit what this feels like with this COVID-19 situation, right? Even when you and I were talking before we came up here, you got a siren alert from the state and I need to look at that and see, have things changed? Because probably the moment we post this video, something is going to change. And that's just part of what we're dealing with right now and trying to stay with accurate information.
So as a researcher myself, I'm just really excited to watch this area evolve, but the information is changing daily. And so this has created a tremendous challenge for scientists, for frontline workers, for hospital administrators to really figure out how do we mobilize and respond quickly to help our communities be safe. And in the end, that's what it's all real about, is that, you know, this is the work that we've prepared for. And I had this great conversation last week with one of my colleagues at Memorial, and we were discussing about how demanding and challenging this is, and she was really complimenting the hospital around our response. But she said, I see this now. This is not a drill.
It's not. It is not. And this is the type of thing we have prepared for, and we've been through the scenarios, and we've practice it, but
Yeah.
this isn't a drill.
But
this is real.
now we must respond,
Yeah.
and we understand that our responses are not always perfect and complete at the front line,
Yeah.
but we will keep working to get it right.
Yes, I would agree. I think one of the things that we've talked about a lot in the command center is that I think we could probably all agree we've never worked so hard for so long, right? The hours, this has been nonstop since I think March 8th was the day we stood up our command center, and it hasn't slowed down, and it just,
Right.
we're on that incline. I don't know that within healthcare in general, whether you're talking about physicians, nurses, pharmacists, the EMS, first responders, the leadership team in the background, all of the support roles, the people that we call our clean team that are out there keeping it clean. I don't know that anyone's ever worked this hard for this long, but I would also say I don't know that it's ever been this important, right? Because of what we're trying to do. And so every day we're making sure we're providing care to people in our community for whatever it is that their needs are. Now we're just at this time where there's kind of this, the general community has the same need, and we're trying to fight that together.
Right.
Yeah.
No, and I've been in healthcare myself for decades. I've seen many different things happen over that time. I really have never experienced anything like that, but I do feel like this is what we've been prepared to do. Right. And this is what we need to do for ourselves, our patients in the community. Absolutely. We will keep working to get it right.
We will. And I'm sure that everyone who is watching really appreciates your insight. One of the challenges I had in trying to say, can I get Linda to come do this, is pulling you away from the important work that you're doing. But we really believe that if we can get the community to understand better testing, what it looks like, how do you get a good sample, where do we test at, how does it take this long, how can I get tested? The more they know, the better informed they are, the better we can serve people. So we really appreciate you being here today. Any final thoughts that you want to share with people about?
I just would like to say to our patients and families, thank you for entrusting us with your care. And while we know that this has been difficult and challenging, we're here to support you, answer your questions, and help you through all of this.
Yeah, so if people have questions, they can certainly comment them on this video, and we'll do our best to answer those. Dr. Jones, thank you for being here so much, for sharing your knowledge and your wisdom, your unique background of being a registered nurse, having your doctorate in nursing practice, being our research expert in the organization. It feels like it's all come together in this perfect storm for you to serve as our testing director, and we really appreciate that. Thank you.
Thank you.